学医学院济宁市第一人民医院的客座教授，是超声新出量监测技术的发明人。总共发表了论文超过700多篇，其中 SCI 论文就超过了400篇。获得过多项国家自然科学基金、国家临床重点专项等项目的基金的支持。下面有请罗伯·菲利普斯教授。
谢谢 and thank you very much for your welcome. Professor Lay, your team, moderators, it's my great pleasure to be here today to talk to you after a number of years not being able to meet face to face. There's something very good about being able to talk to each other about clinical care.
早上好，我是来自澳大利亚昆士兰大学的 Rob Phillips 教授，非常感谢大会的邀请，非常感谢雷教授邀请我到现场面对面跟大家进行交流。
Today I'd like to talk with you about common clinical problem, sepsis, its relationship to circulation, and specifically the changing emphasis into precision medicine.
今天我演讲的主题是脓毒症、循环和 ICU 里面的精准医学。
And really what it's about, well, the point that I would like to make is sepsis is common, it's dangerous, and we can approach it from a different point of view to improve outcomes.
那我们知道脓毒症发病率很高，死亡率也很高。那么我们通过精确的治疗的话，是可以改善预后的。
If you look at the simple display here, what we can see is we have targets and we have accuracy. So what we measure and how accurately we measure means the effectiveness of our therapies can be better guided.
那我们看到我们是有治疗的目标，然后我们要有精确的一个监测，那么这样的话才能达到我们的一个治疗的要求，改善预后。
How do I advance? Here we go. Yeah, so the summary is it's very straightforward, and that is if we do this, we get it wrong in all patients. This, we get it right in some patients. The third, we get it wrong in all patients. What we really want is to get the measurements right so that we can adopt the correct therapy.
我们需要做的话是找到我们正确的监测的目标，找到那个正确的病人，从而那个改善病情的结局。
So measuring the right thing very accurately allows us to treat appropriately.
还是我们要那个监测正确的目标，然后找到正确的一个路径。
What's essential, of course, particularly with sepsis, is to understand that every patient, every subject is different. And therefore, size, weight, gender, physiology, efficiency, diurnal, training, altitude, temperature, the list is huge, is different.
每个个体都是不同的，那包括我们的体重、我们的性别、生理状态都是不同的。
And what's important about that is if we apply the same mode of treatment, a protocol, then we will get different results for every patient.
那么我们如果使用同样的方法治疗每个不同的病人的话，那可能得到的结果也会不同的。
If we look at it quite simply, it's really about guidelines and protocols treat average patients, whereas precision medicine is designed to treat every patient.
那之前的话，我们都是遵循指南，但指南的话是治疗的一个病人的群体。
And so what does this have to do with sepsis? And let me tell you.
那么精准医学可以在脓毒这方面做哪些工作呢？
Sepsis is extremely common. Up to 20% of all ICU patients. 8.68% of ICU patients have severe sepsis, and it still has a mortality of 30 to 50%. So it's an incredibly serious disease, common, expensive, and frequently fatal. This is worldwide.
脓毒症的发病率非常高，20%。那重度脓毒症的话，可以达到8.68%。它的死亡率的话也是非常高，可以达到48.7%。那么它是一个非常可怕的一个疾病。
worse than it being worldwide, for all the effort that we've put into improving sepsis and septic shock management, worldwide, the mortality associated with sepsis has increased, probably related to antibiotic resistance, etc., more common infection rates. No matter what, sepsis is increasing in incidence despite other treatments bringing down a whole host of other pathologies.
那过去的20年的话，脓毒症的治疗的结果并没有明确的改善它的死亡率仍然非常高，可以达到40%到50%。
So what that tells us is there is something that we're not doing right. So the first response to that is how do we standardize treatment? Maybe protocols improve outcomes.
那么我们是不是在某些方面做的不对呢？那之前我们治疗脓毒症的话都是遵循指南，那么每个脓毒患者的话都会接受液体复苏，然后等等这些标准化的治疗。
However, in the last 3 decades, more than 100 phase 2 and phase 3 trials have been performed, but they have ultimately failed to improve outcome.
过去的30年的话，大概有100多项的2期或者3期的临床研究，那这个研究的话，并没有得出一些明显的阳性的结果。
And mortality still remains 30 to 60%.
死亡率的话仍非常高，可以达到25%到50%。
So there must be something we can do better.
我们可以做得更好。
Protocols aren't the solution. Patient-precise approach to therapy. Treat each patient with each disease.
那指南的话，其实不是最终的解决的方案，而是要对每个病人进行个体化的一个治疗。
Sepsis isn't one condition. It's caused by multiple pathogens, and it causes multiple pathophysiologic responses, multiple immune responses, and they are different for each individual.
脓毒症的话，它抑制性其实非常高，它有不同的这种病理生理的过程，有不同的免疫学的一个状态。
So let's look at some old-fashioned advice. When it's obvious that the goals are not being reached, don't adjust the goals, adjust the actions. So if the protocols don't work, try something else.
那么有一句中国的古话叫“设有似乎君子，失诸正乎，反求助其身”。其实是他的意思，就是说，如果我们达不到目标的话，我们不应该改变目标，而是去改变行动。
So let's consider another complication. Autopsy studies have failed to recognize why patients die with sepsis. We know that increased oxygen demand and decreased oxygen supply leads to hypoxia, organ failure, and ultimately death of the organism. But what we do know is all patients who die with sepsis have circulatory failure.
有意思的是，很多的尸检的话，它并不能告诉我们脓毒症的真正的死亡原因。那我们知道，脓毒病人的话，他的氧耗是增加的，然后他会出现一个缺氧。那我们还知道的是，脓毒症患者的话，最终都会出现循环的一个衰竭。
So this gives us a clue. This says perhaps we're looking at the wrong thing. If we look at circulation, and the circulation is absolutely fundamental to our existence, we know that it's the beating of the heart that drives the erythrocytes that are carrying the oxygen to the cells. So this is a vital clue. If circulation is what keeps us alive, and in sepsis, a lack of circulation kills us, maybe we should focus on the circulation.
那我们从血流动学开始，那血流动学的话指的是血液的流动，然后红细胞携带氧气。那输出量和氧输送的话是血流动学的一个重要的组成部分，这些都是生命的一个基本的要素。那我们知道血流动学的话是我们治疗的核心，包括循环。
Obviously, this is the explanation. Oxygen comes into the lungs, transported in the blood via the heart, macrocirculation through the vessels, into the microcirculation, into the mitochondria, and into ATP. So if we interrupt that delivery of oxygen to ATP at any point, the organism will die or the organs will be impaired.
们看一下呼吸系统，氧气吸入到我们的肺，然后进入血液循环，通过心脏碰到全身血液系统，然后到微循环，从而产生 ATP 就是能量。那如果其中的任何一个环节出现问题，会导致机体的一个缺氧，产生一个机体的损伤。
So it's really quite simple in first principles terms. Adequate oxygen is essential for the survival of cells, organs and organisms. Inadequate O2, death of the cell, organs and the organisms. So maintaining adequate DO2 is really important.
足够的氧的话，对细胞、器官和机体的存活是至关重要的。那缺氧的时候会导致细胞、器官和功能的这个损伤。那么维持足够的氧供的话，是机体生存的基础。
The other thing which complicates the treatment of sepsis over time is that the pathophysiology actually evolves. So if we start here, we've got normal blood pressure, normal SVRI, normal stroke volume, normal oxygen delivery, and normal consumption. As we get an infection, then the oxygen demand increases. The VO2 increases. The oxygen delivery increases. So this is normal compensation, normal infectious compensation. Once we move beyond stage 1, we move into a response, an immune septic response. And suddenly the DO2 diminishes because the stroke volume diminishes. We get a cardioplegia or vasoplegia. So stroke volume starts to drop and the systemic vascular resistance starts to go up to preserve the blood pressure. Blood pressure is maintained. What's important is throughout this cycle, the demand for the cells for oxygen, the VO2, increases. And the rest of the physiology is fighting to deliver adequate oxygen.
那这张图其实是展示的脓毒性休克的一个疾病的一个过程。那么我们看刚开始的时候，其实机体会产生代偿，它氧耗量会增加，氧输送、镁铂量、系统循环阻力这个血压的话，它们这段时间会有一个明显的变化。第一个阶段的话是镁铂量它会增加，氧输送会增加，血管阻力会下降。那这时候的话，血压尚能保持正常。那么第二个阶段的时候，然后它就会变得复杂一些。那么这时候会出现心肌的麻痹，然后会出现镁铂输出量和氧输送的一个减少。那同时呢，全身血管阻力增加，以维持充足的一个灌注压。那这时候的话，血压开始会下降，那么就从代偿期转为一个失代偿。那么失代偿阶段的话，它的氧耗量其实也是增加的。那血管它无法保持收缩，维持有效的一个血压，随之带来的话是氧输送的一个不足。那么心肌麻痹和血管麻痹是循环失代偿期的一个特征。
So the septic process, if it's allowed to continue, takes us from normal to death. And that's a response of inadequate oxygen supply. And what you can see here is that the DO2 from here starts to drop. Oxygen delivery is diminished and oxygen demand is maintained high. These are the more complex stages of sepsis and septic shock. And unless we address and draw back the physiology back towards normal, these patients will die.
那从这张表上我们看到，在第一个阶段之后的话，它其实出现一个氧输送的一个明显的减少，但是同时的话，它的氧需求反而是增加的。那这时候会出现一个氧供和氧耗的一个明显的一个不匹配，病人会滑向一个死亡的一个深渊。那如果我们能够在早期的阶段阻止这种变化的话，那可能会挽救病人。
But this process is actually more complex because the effect of sepsis, the immune response, the cytokines, they act differently on the vessels and the heart. So here you get a cardiogenic or cardioplegia, and that's the pathway to finality. This is a vasogenic or vasoplegia. And what you can see is the compensation and the hemodynamics are entirely different. And so the way we manage it is entirely different. We need to think about both of these diseases in a different way. And we need to approach them in the way. We can't say, this patient has sepsis, we'll give them some fluid. There are many things that can go wrong. It's a complex process and it's a personal process. No two patients are the same.
那这两张表其实展示左边的话，我们看到是一个心源性的一个衰竭，那右图的话是一个血管源性的衰竭。那其实脓毒症的话，它有很大的这种抑制性，它的这种心脏和血管的反应也是不同的。那所以我们要针对每个病人的具体的情况进行具体一个处理。
So, what can we do? Decreasing DO2 to meet an increase in VO2, survival requires us to augment the DO2.
机体的话，它会在为氧供和氧耗的这种不平衡进行一个骤增。那生存的关键的话是取决于足够的一个氧输送。
This is Guyton's contribution from 1955, and it's fundamental. We can treat the stroke volume, which increases oxygen delivery, and we can reduce the systemic vascular resistance. So we have three therapies for the circulation. We've got fluid, inotropes, vasoactives, but we don't know which to use until we can accurately measure stroke volume and systemic vascular resistance, the two regulators of oxygen delivery and cardiovascular control.
那我们看到这是平均动脉的公式，平均动脉压的话，它就等于心输出量乘以我们的心率，然后乘以系统的一个血管的阻力。那么治疗的方式的话有3种，一个是液体，一个是升压药，还有就是血管活性药物。那么其实我们并不知道具体应该用哪一种的药物，那所以我们要监测SV 就是镁铂量和监测 SVR 就是全身血管的一个阻力。
So, what are the numbers that we need to use? What can guide us to the next stage to being precise in the therapy that we deliver to each patient?
所以我们究竟是要研究哪些参数才能真实的反映个体这种生理情况呢？
Here's a little graphic that describes the measurements that we can make, the therapies that it guides, the physiology that it affects, and the pathway to oxygen delivery. But what's important for this is it all goes through stroke volume and oxygen delivery. These are the parameters that tell you or predict what the survivability of your patient will be.
那这是一个流程图，那它展示了液体强心药和血管活性药物对前负荷、后负荷的影响。那么它们都会影响我们的镁铂量，那镁铂量的话会影响心输出量，心输出量会影响氧输送。
So this is a way that we've been using, and what we do is we simply use a Doppler device to measure directly into the ventriculoarterial valve. Get a readout of the stroke volume, freeze it. You now know what the stroke volume is. We also know what the systemic vascular resistance is. These are the measures that we can generate, and that's what will guide the interventional therapy of fluids, inotropes, and vasoactives.
那刚才那个视频的话，其实是用Uscom 超声，然后进行一个镁铂输出量一个监测。那它很简单、准确、可靠、快速，在床边就可以完成。那么它得到的这些参数的话，其实都是一个动态的变量。那么通过测镁铂输出量，还可以得到很多其他的一个血流动力方面一个参数。
And if we plot it out, we can actually look at what the normal values are from 0 to 100 years old. And we can work out whether we need to push the inotropes up or down, or vasodilators up or down. And that gives us a very simple pathway to steer our patients towards normality or normal circulation at least.
那这是展示了我们强心药、液体血管扩张剂、血管收缩压怎样去调节一个机体的一个生理一个状态。那么要进行一个动态的监测来评估它们是否有效。
These are the longitudinal plots that is work that I've worked on for quite some time, and looking at how DO2, normal DO2, and DO2 indexed varies over lifetime. And that tells us at any age what values we should be looking at. But remember, if someone has sepsis, we don't want to deliver normal DO2. We want to give an elevated DO2 because there is already hypoxia in the tissues. So the hemodynamic target in sepsis is an increased DO2.
那图表展示的话是 DO2 就是氧输送随时间的一个变化和氧输送指数的一个变化。那我们看到氧输送可以正常，也可以是增加或者一个减少。那么我们知道那个脓毒症和脓毒休克的时候，它的氧需求的话是增加的。那所以我们设定的氧输送目标的话，不是正常，而是应该高于正常的。
We could look at it from another point of view and look at the Frank-Starling curve. Once we've got a stroke volume model, we can look at how we use fluids, diuretics, inotropes, positive and negative, and vasoactives, dilators and constrictors.
这是那个 Frank-Starling 曲线。那么我们看到，我们需要精确的这个液体付出既不能太多，也不能太少。那强心药物和血管活性药物的话，也是同样的道理。我们要保证足够的氧输送，同时又不能使心脏过度负荷。
What we can do once we have those numbers is apply it to a model. So here's a simple hemodynamic optimization using fluid. Give fluid. If the stroke volume increases, stop giving fluid. If it doesn't stop increasing, you go back and give more fluid. So elementary, but perfect physiologically. And it's not the volume of fluid, it's the physiologic result that we're aiming for. We want to get the right stroke volume, not to give 1 litre or 500 mils or 2 litres. Get the right stroke volume. Once the stroke volume stops going up, you stop giving fluid.
那其实可以利用这些参数来制定一个简单的流程，以指导液体付出。那如果给予液体了之后，患者的美国量增加，那么它就具有液体反应，那么可以继续给液体。那如果给液体之后容量进输量不能增加，那么这时候就达到一个付出的一个终点。那其实我们要知道的，我们不是要给予100或200毫升的液体，而是要关注美国输出量。
But remember, the end point is to get a normal oxygen delivery.
重点的话是我们要达到一个我们的目标的一个氧输送。
We can then apply the same principle to a personal hemodynamic pathway, say for heart failure. Fluids, inotropes, vasopressors, vasodilators, maybe transfusions, we don't know. But ultimately, it's deliver the right DO2.
那这个流程展示的是对于一个心衰的患者怎样进行一个液体复苏。那我们看到它有液体有强心药，还有一个血管活性药物的应用，然后同时的话也是要监测这些治疗的反应。
The same thing, this is the sepsis pathway. And what we've done there is you increase the oxygen delivery by 30-odd%, 25 to 30%, because the tissues are under stress and they need more oxygen.
那这是关于脓毒症和脓群休克的一个流程。那脓群休克的话，这类病人的氧输送是往往比较高的但是关于病人的话，他的全身血管阻力是低的，所以这种病人的话，重点要增加氧输送。
But the goal and target is oxygen delivery.
目标核心的目标的话，还是氧输送。
So does it work? Does it impact? Does it change outcomes? And this is some really elegant work from Joe Carcillo and Akash Deep at King's College and Pittsburgh. And what they did was they distinguished the hemodynamic characteristics of those folk with high oxygen extraction and low oxygen extraction. If your oxygen extraction is low, your survival is high. If your oxygen extraction is high, your survival is low.
那这是一项来自英国的研究。那可以看到，左边这个图，脓毒症的幸存者和非幸存者的话，它在氧摄取方面是有一个明显的差异。那氧摄取，可以预测脓毒症的这种幸存者和非幸存者。
Here's a real-life application of stroke volume-guided resuscitation. And this is at the critical care environment in King's College in London. And what they did was, by treating children early with stroke volume-guided therapies, they reduced paediatric mortality in their community by 35%.
那这是一项来自英国国王学院的一项研究，他们治疗浓度重的儿童的患者，那使用以美国缩动量为指导的一个方法进行个体的一个管理，那死亡率的话是从17%降到了11.1%，下降幅度达到35%。
While these findings are relatively preliminary, there are a couple of very substantial multi-centre trials going on with large sample volumes that are finding similar results to these that will be published in the next few years.
那么现在进行的一项研究的话，也是有类似的结果，那么将会在杂志发表。
But what's important about it is that it makes sense physiologically and pathophysiologically, and that's really important. This is community applied protocol in adults, and what it shows is that compared to the Australian national, it's reduced from 24 to 6%. So it's a substantial decrease, and certainly much lower than any of the other alternate community reported incidences of mortality and septic shock. So these are all indicators, and there are more specific studies going on at the moment that are showing similar numbers. And it shouldn't be a surprise for cardiovascular physicians, ICU physicians. Treat the pathophysiology. Don't protocolize.
那这是一系列在澳大利亚进行的一些研究，那么它从那个 Rivers 一直到Australian National 一直到 Bush， 那就是之前的话，这种死亡率的话并没有明显的下降，直到Australian National 研究死亡率会下降到了23.9%，那到 Rush 的话死亡率进一步降到5.8%。那这研究给我们的提示是的话，我们要根据患者的病理生理学状态进行一个精确的一个治疗。
So, in summary, it's use the right target and be accurate. Precision medicine is a revolution in critical care. Current guidelines are generally not effective. Precision guidance of fluid inotropes and vasoactives is critical, but avoid monitoring to BP, CVP, lactates. These are delayed surrogates of circulation. Trend monitor hemodynamics. Look at the change. Look at the shift. These are indications of improvement or deterioration. Physiologic precision targets, stroke volume, systemic vascular resistance, cardiac output, and indices of inotropy. These are what tell us, and of course DO2, these are what tell us about survival.
最后总结一下，那精准医学是重症医学的革命。那目前的指南的话，其实并不可靠。那么精确的指导液体付出、强心药和血管活性的药物，应该是接下来的一个工作。那替代的指标，比如说血压、CVP、乳酸等，它具有误导性，不能及时反映患者的一个病理生理学。那么重要的是，我们要对血流血动力状态进行一个动态的一个监测。然后我们要监测镁铂量、系统血管阻力、心输入量和氧输送。
So, it's Confucius who gets it right again. Life is really simple, but we insist on making it complicated. It's about DO2. So, thank you very much for your time. Would you like to just... Sorry.
最后引用一句孔子的话进行总结。生活其实很简单，但我们偏偏把它复杂化了。那么其实我们要监测的是氧输送它具有具有生理意义和实际意义，可以改善预后。谢谢大家。
Thanks, Dr. Han. Thanks very much.
Thank you.
非常感谢。非常感谢罗伯·菲利普斯教授的精。